بسم الله الرحمن الرحيم. طلابنا الأعزاء، السلام عليكم ورحمة الله وبركاته. Our lecture today is about the acute and chronic infections of the larynx. At first, we must know the clinical manifestations or clinical features of acute laryngeal infections. These including changes or loss of voice or difficulties in breathing, which is called stridor, or sore throat and othalgia, difficult or painful swallowing, tender larynx with or without cervical lymphadenopathy. The first subject is the acute laryngitis. The acute laryngitis is a common inflammatory condition that affects the vocal folds and supraglottis. The usual causes include viruses, mainly the adenovirus and influenza virus, which are associated with upper respiratory tract infection. Secondary to the infections of the tonsils or the chest, as in acute tonsillitis or acute pharyngitis or bronchitis. Third, inhalation of dust and fumes. Fourth, underlying allergy. And 5, bacterial infection like Moraxilla catarrhalis. The clinical features of acute viral laryngitis, which is normally self-limiting disease that resolves after a few days. Patient will have a rough, deep voice, on occasions become aphonic. Voice changes are usually preceded by the symptoms of common cold and sore throat. Examination will show the erythema and edema of the vocal cords, and there may be excess secretions in the larynx. Bacterial superinfection will induce a more severe degree of laryngitis that may persist and become chronic. Management of this patient: the disease usually resolves completely over 1 to 2 weeks, and the investigations are unnecessary. Basic therapy include vocal rest, avoidance of irritant and steam inhalation, analgesia, antibiotic if bacterial superinfection, or patient rely on their voice professionally, like in singers. Throat discomfort sometimes occur, but the larynx looks surprisingly normal. The likely explanation is that the residual dysfunction is due to persistent inflammation within the internal laryngeal muscles. Speech therapy is indicated if the problem persists. Management of professional voice users with laryngitis includes systemic steroids, antibiotics, mucolytics, vocal rest, and attention for hydration. The second subject is acute epiglottitis. Acute epiglottitis or supraglottitis is acute infection of the supraglottis that affects primarily the epiglottis, but can include the other sides such as the lingual tonsil, epiglottic folds, and false cords. Epiglottitis affect all age groups. The main difference in the children compared to the adult is that the acute epiglottitis progress very rapidly and compromise the airway. Microbiology, including Haemophilus influenza type B, which was the commonest pathogen especially in children. In the adult, it includes Streptococcus pneumoniae, Staphylococcus aureus, and Klebsiella pneumoniae. Clinical feature: it is most common between the age of 3 and 6. Acute painful sore throat, dysphagia, and odynophagia. Adult epiglottitis differ in children. The airway obstruction may be not present. Cervical lymphadenopathy is common. Also, the patient complain of drooling, respiratory distress, hoarseness, and edema of the palatine arches and uvula. Stridor is uncommon, but tachycardia that is disproportionate to the pyrexia is important sign that precedes the airway obstruction. The child will be sitting in upright position. This is called the tripod signs. This is the tripod sign. Investigation: When acute epiglottitis is suspected, pharyngeal examination should not be attempted, as a manipulation by tongue depressor may precipitate acute airway obstruction. Although the use of fiber optic or small rigid endoscope can assist the diagnosis in patients with atypical presentation. This picture shows the typical picture of inflammation and edema of the epiglottis or supraglottis. White cell count is important and significant when the patient with impending airway obstruction develop severe leukocytosis. Plain lateral soft tissue radiograph of the neck, including two signs. These are the thumb sign, which is due to the thickening of the epiglottis, and the absence of deep, well-defined vallicular cord, the vallicular sign. So we have two important signs. CT scan useful if there is complication such as epiglottic abscess. This picture shows the typical presentation on X-ray, plain X-ray. On the right picture there is what's called thumb sign, while in the left picture there is a vallicular sign. This is another picture show the severe swelling of the epiglottis. Management of this patient: the patient should be admitted and observed. Secure the airway by intubation or tracheostomy if needed. Intravenous antibiotics using second or third generation cephalosporins. 100% humidified oxygen. Complications include death from respiratory arrest due to acute airway obstruction, epiglottic abscess, pulmonary edema secondary to the relieving upper airway obstruction, and Lemierre syndrome. We have another subject which is called the laryngotracheobronchitis or croup. It is acute illness with hoarseness and barking cough and stridor. Croup affect mainly the young children aged 6 months to 3 years, in which subglottic edema lead to early respiratory distress and biphasic stridor. In contrast, adult croup is an uncommon condition. Laryngotracheobronchitis is usually caused by viral infection, in which the paramyxovirus, parainfluenza type A, type 1, and type 2 are commonly implicated. In adults, infection may also occur from the herpes simplex, cytomegalovirus, and influenza virus. Adult croup is rare and impaired immunity should be considered. The characteristic feature of this specific form of laryngitis is the subglottic edema. Clinical feature of the patient: the adult croup present in a similar way to the childhood croup, but it is more severe illness in the adult. The illness usually present with a cough, sore throat, malaise, mild fever for 2 to 4 days. Deterioration can be rapid, and signs include shortness of breath, stridor, and inspiratory retraction of the soft tissue of the neck. The endoscopic appearance of the larynx will show the normal epiglottis, but inflamed vocal cord and subglottic edema extending into the trachea. Investigations including the viral antigen detection by sampling of the mucus from the nasopharynx to identify the pathogen, and a plain neck radiograph may show narrowing of the subglottic area, which is called steeple sign. This is the steeple sign in the X-ray. Of this patient include oxygen, steroids, neobulized epinephrine. Oxygen saturation should be monitored. Intubation used if the airway impaired. Broad-spectrum antibiotics are advisable to cover the secondary infection, but there is no evidence to support the antiviral agent. Also, should give adequate fluid rehydration. We have another subject, which is the diphtheria. The diphtheria is caused by Corynebacterium diphtheriae and spread by droplets from the upper respiratory tract of an affected individual. The disease is caused It affects the non-immunized children and susceptible adults, particularly the elderly. The usual site of infection is the tonsil and fauces, but it can also be occur in the nasal cavities or spread to the larynx. The clinical feature of the disease characterized by severe sore throat, malaise, pyrexia, and nasal discharge. If the nose is affected, examination of the throat show characteristic gray membrane in the oropharynx, and this may be spread to affect the larynx. Cervical lymphadenopathy, enlarged and tender. Investigation including swab from the throat and or nasopharynx of the grayish membrane. If present, should be sent for screening. Management include treatment with antibiotic. Benzyl penicillin is the drug of choice. Second, antitoxins. Third, acute upper airway obstruction should be managed with intubation, and close contact relatives should be immunized. Complications. The diffusible exotoxins has predilection for cardiac and renal tissue. So cardiac complications include myocarditis, arrhythmia, and possible death. Neurological complications due to exotoxins may be developed a few weeks after the acute infection. The most frequent involve the soft palate paralysis, but also may affect the diaphragm and extraocular muscle. Scarring of the oropharynx and the nasopharynx due to fibrosis and adhesion formation. Also, the patient develop renal damage. We have another subject which is called laryngopyoceal. A laryngocele is an abnormally large laryngeal saccule that contains air or mucus and has an opening that's connected with the airway in the laryngeal ventricle. It may be internal within the laryngeal skeleton, external, or combined. Presentation can be at any age, but the peak incidence is in the 6th decade, most commonly in men. If the laryngocele contains mucus, stasis will be predisposed to the bacterial infection and causing laryngopyoceal. This is a typical picture of external laryngocele. External or combined laryngocele present as intermittent neck swelling that can be inflated by Valsalva maneuver. Compression on the external swelling may be empty the air and fluid into the larynx. This is called the Bryce signs. Distension of the internal laryngocele due to infection may cause airway obstruction, and also it can be induced hoarseness, dysphagia, and sensation of the lump in the throat. Examination of the larynx will show the swelling of the supragluteus on the affected side. There is association with squamous cell carcinoma of the larynx, and the laryngeal ventricle should always be examined by endoscope. Investigations include the sac contents can be differentiated by ultrasound, also by CT scan, MRI, especially if containing mucus or in the presence of the fluid, also X-ray. This picture shows this is the laryngocele by the imaging study. Include the main reason for the recommendation of surgery is that 10% of laryngocele present with infection. A laryngopyoceal should be treated with intravenous antibiotic. If cellulitis progress to form an abscess, aspiration and drainage will be necessary, and airway obstruction may be require tracheostomy. Once the acute infection has resolved, the laryngocele should be excised. Excision by external approach, but this is maybe combined with endoscopic surgery. Recently, complete endoscopic excision of the internal and external component with the aid of CO2 laser has been described. Another subject is the mycotic laryngitis. Most fungal infections of the larynx are caused by inhalation of the fungus in association with breakdown in the normal tissue defense mechanism. Clinical feature: the patient present usually occur in the patient with immune depression, as it is rare in normal immune patient. Patients with compromised immune system, and particularly those with hematological malignancies, are prone to acute infection from these opportunistic pathogens. Mycotic laryngitis, except the superficial candida, usually cause ulceration. The most common predisposing factor is the recent treatment with antibiotics, inhaled steroids, diabetes, chemotherapy, radiation therapy, smoking, acid reflux, and inhalational or thermal trauma. The characteristic finding in the larynx is a white pseudomembrane or adherent white plaque. It can also appear as a diffuse erythema with edema and ulceration, infection like seen in this picture. This is another picture with diffuse fungal infection. Investigation: pulmonary fungal disease should be excluded at first by chest radiograph. Direct laryngoscopy and biopsy may be required. In the more chronic variety of fungal infections such as blastomycosis, which can appear as laryngeal tumor and is only differentiated by laryngeal biopsy. Management of this patient, including systemic antifungal, especially in immune-compromised patient. Antifungal agent is only suppress the fungal growth, and recurrent infection is therefore likely unless the underlying predisposing factor is corrected. Another subject is acute perichondritis, which is the inflammation of the laryngeal perichondrium. It is caused by either primary, which is due to blood-borne infection, or secondary due to laryngeal infection spreading from deeper tissue, or radiotherapy or autoimmunity like relapsing polychondritis and SLE. Clinical feature is slowly developing with dull pain over the larynx, fever, malaise, airway obstruction, cartilage necrosis, and foul-smelling discharge. Treatment by broad-spectrum antibiotic, steroid dressing, intubation or tracheostomy if airway obstruction, and total laryngectomy in resistant cases. These are the acute infections. Now start with chronic infections. First is the chronic non-specific laryngitis, which may be present with a wide spectrum of signs and symptoms and severity. Patients invariably present with a degree of dysphonia and maybe have associated symptoms such as throat discomfort, awareness in the throat, globus, throat clearing, halitosis, or otalgia. The most etiological factors including smoking, voice abuse, and GERD. There are two principal theories to explain this. Firstly is the direct theory with reflow from the stomach and esophagus crossing the upper esophageal sphincter and causing inflammatory effect on the laryngopharynx. Secondly is the indirect theory where the chronic repetitive throat cleaning and coughing is caused by vagally mediated response secondary to the acid in the lower esophagus. Grading system of chronic laryngitis including grade 1 mild erythema with string signs, loss of light reflex stasis of secretions. Grade 2 moderate erythema, granulation or mucosal surface or ulceration. Grade 3 there is a marked edema, granuloma formation. Treatment include first treatment of the cause. Empirical treatment with PPI proton pump inhibitor is advised in patients with GERD. Voice therapy is advised. Stopping smoking and lifestyle modification will be appropriate. This picture shows the patient with chronic laryngitis as examined by laryngoscope. Another important subject is the TB laryngitis. This is occur with patient with pulmonary TB. The patient complaining of dysphonia, pain on speaking and swallowing, and otalgia. This is diffusely red and edematous larynx, predominantly affecting the posterior 1/3 of the gluteus. There may be ulcerations and appearance may be confused with squamous cell carcinoma. Diagnosis made by biopsy. Treatment to secure the airway followed by anti-TB drugs. Complications include stenosis and vocal cord fixation. This picture shows the patient with TB in the larynx, and also this is another picture. Other subjects include syphilis. The larynx is rarely involved in this condition, although each of the stages may occur. The secondary and tertiary stages of the disease are more common. Hoarseness and dysphagia are common, but pain is rare. There are diffuse erythematous papules in secondary stage and nodular infiltrates, coalescing into the painless ulcer which is occur in tertiary stage, with the epiglottis and epiglottic fold being the principally involved. Appearances are similar to those of the TB and carcinoma. Diagnosis by positive syphilis serology, treatment with high dose penicillin, and this picture shows patient with syphilitic laryngitis. Thank you very much for listening.